Hey, thank you for joining us tonight. I know it's a weekend, so we're glad you're here. And like Jeff said, there is going to be 2 hours of CE credit, and all we have to do is get your email to be able to do that. So what we're going to do first is we are going to start with Richard Moore. And Jeff, are you going to introduce him?
You know, this is a lot of fun for me. And one of the fun parts of this is oftentimes you get to do these webinars with your friends, and that's certainly the case today. I would say of the people on our panel today, the first person I'm going to talk about, Richard Moore, Dr. Moore, he's, I would say, my newest friend. It sounds kind of like high schoolish, but we met this year, and it was a very interesting kind of the way we met. And he expressed an interest in putting on a webinar, and we started talking, and we just kind of hit it off, I guess you would say. And Dr. Moore has remarkable accomplishments in his career. He created Talon, so many of you, if you're familiar with materials, you can thank him for that material. He founded Comfort Acrylics, which is a dental lab. And I think the project that's near and dear to him is his .MAD program, and he's going to talk a little bit about that, but that has to do with what he's going to be talking about. So I'll let him spend some time talking about .MAD. And he said, you know, I have to say I've learned quite a bit. He's, you know, I've been around for many years in the medical sleep diagnostic and product development, and he's been around the same number of years on the dental side. So he's, we're kind of old school sleep people, if you will, but from different sides of the track. So that's Dr. Moore. Marty Lipsey, he's a dentist that does medical billing. And Marty and I have met many, many years ago. He's been helping dentists succeed, arguably is the most difficult aspect of dental sleep medicine, and that's billing medical insurance. And I have to say that we have kept in touch this whole time. When we've more recently, we've kind of upped our time that we've been communicating, and I find that his information is vital. And it's like I said, he specializes in the area that many of us would say is probably the pain point in dental sleep medicine. So I look forward to hearing what he has to say. And then Suzanne Miracle, Dr. Miracle, and I have been friends for 12, 13 years now. We've known each other, and it's been an exchange of ideas, and we've been working together. She always credits me for teaching her about sleep. And to the extent that I've taught her about sleep, she's taught me about dentistry, because I am not a dentist. And in fact, I would say that my medical background was, I would characterize it as a liability when working with dentists, because it's not the same. You know, working with a physician is not the same as working with a dentist. And Dr. Miracle has taught me those differences. And I'm very happy to be able to say I'm a much better prepared person to work with dentists than I was when I first started, in a large part due to Suzanne. So that being said, Suzanne, did you want to say anything else, or should we just get started?
Let's just get started. It's Friday night.
All right, Richard, if you're ready, I'm going to go ahead and hold on just a moment here. I did want to mention that this program is put on by Practical Sleep Education. We like to say sleep well to be well. You know, certainly we know that that's the case. And here we go. So Richard, you're on.
Well, thank you very much, Jeff. I'm flattered to be your new friend. It's wonderful, and you're a great resource. Are you bringing up that slide? The slide?
Yes, I will. Yeah, let me get it going.
My role here, and it's rather limited time, so it's kind of difficult to get into too much detail about this topic, but my role is just to talk about the experiences I've had in combination therapy for those patients for whom CPAP was unacceptable or intolerable, and the oral appliance was perhaps not fully treating the patient. So it was a natural thing to begin to combine the two therapies. And if you show I'm sure you've all seen patients like this come in showing you what they're doing or what they failed at, and it just seems kind of comical. And so it's led to other thoughts in the matter and different ways of the evolution of combination therapy, which for me, actually, Jeff, you could change slides, please. First, let me say that I can't escape the biases I have here. Over the past many years, I've been developing products, and I just want that to be very clear that I'm biased in all of these opinions. There's several products associated with the oral appliance that facilitate the combination therapy, and many of which are still in various stages of prototyping, but all within the patent office. So keep it in mind that I cannot escape this bias. Next, please. This is where we really started. Back in the early 90s was a pulmonologist out of California knew I was doing some things in this, and he wanted to try to develop the administration of positive airway pressure through the mouth. For patients for whom the nasal airway was too compromised to correct, and also for non-invasive ventilation for ALS patients and similar types of uses there. He was quite convinced that the airway could be managed through the mouth, but we had quite a bit of trouble. The FDA study to get it approved was quite impressive. The data there, which is somewhat obscured, generally showed a fantastic reduction in respiratory disturbance index, and but it was intolerable. It taught us that positive airway pressure through the mouth is not a good way to go. It was confirmed with just because the patient's tolerability or intolerability. Fisher and Paykel company came up with the Oracle interface, which tried to do the same thing. And I don't think they fared much better. Next, but it did teach. It taught about getting rid of straps. It taught about stabilizing the airway in combining with air pressure and the benefits that could accrue from that. And in this case, if we think of conventional HPAP or hybridized PAP or combination therapy, conventional would mean that just the mask is placed over the patient's face or to the nose while they're wearing the oral appliance. And there are many benefits we've seen over the years. I co-founded a practice of for the management of sleep apnea back in 2005. And in the 16 years, we saw more than 13,000 patients. And it's the observations of many of those patients that required combined therapy that led to some of these conclusions. But certainly we would see a reduction in PAP requirements anytime that was combined. And what we found was the higher the titrated pressure was, the greater the reduction was. So when we'd see patients who were over 20 centimeters of water pressure, we knew it would be nearly cut in half if we could just stabilize the airway first. But all of that, reducing pressure, I'm sure you all can just know this, is that it's going to increase the compliance with the therapy. It's the quality of the sleep is improved and the strap pressure is reduced and all of that. So there's some improvement just from that. The most definite improvements we saw, the benefits were the greatest in the full face mask patients, because once the mandible is stabilized, then the lower strap is not moving, retruding the jaw, which is the opposite of what we wanted to have. So if the jaw is stabilized, the mask seals better. And in this combination, if there's a power outage, there's still going to be some treatment and so forth. So there's a lot of benefits to doing it. There's an improved overall apnea-hypopnea reduction. Just because if there's an unconscious removal of the mask, there's still going to be some excellent treatment of the patient, but just perhaps not as good as it could be. So that leads to increased compliance and allows for traveling without the PAP, which is consistent with AASM guidelines. Reduced effects on the dentition. Wearing a device naturally will stop the occlusal traumatism, and in many ways, in the higher pressure cases, you've probably all seen where diastemas form, and there's sometimes even TMD as a result of it all. It can be a safe transition from CPAP too. People with high pressures, that you can just have a very conservative amount of mandibular advancement, perhaps just stabilization. And that even helps considerably to reduce pressure. And as the jaw is advanced, perhaps the need for positive airway pressure could be eliminated. I'm sure you've all seen this stuff, these chin straps that are intended to keep from the leaking through the mouth and getting no treatment. The next slide is another picture that we showed before. So you can think about the oral appliance just as an internal chin strap to keep to prevent the jaw drop in supine sleep. Strapless combination therapy, though, makes even more sense. And the strapless interfaces require a fixation of the interface, either nasal pillow masks or full face masks or EPAP devices directly to the oral appliance, so they're rigidly held. It eliminates all the skin problems associated with straps and tight seals that are pressed against the skin. We noticed that with nasal pillows in a strapped mask, the pressures are limited to anything above 9 or 10, and they'll blow out. And they'll also, if they're moving because of the strap and not being rigidly held, they'll chafe the nostril and cause some problems there. Claustrophobia reduction was quite surprising when the strap is gone. You know, it's the strap itself that may have a lot to do with the patients not being able to do positive airway pressure because of the claustrophobia. And anytime we can keep the mouth shut, that's going to help the proper breathing through the nose. You can just eliminate leaks so much better if the device is fixed and not kind of floating on the skin itself. And the skin it's not as natural as support tissue as the teeth themselves. The teeth feel good to support something rather than the movable skin. This allows to sleep on the back. It's pillow friendly because you can get on your side and not have the pillow itself dislodge the interface. Less is more is always kind of a principle we've seen. You know, if you can eliminate every part of the accoutrements of it that you can eliminate are seen as favorable generally. So it's much easier to replace the interface as well if a patient's returning from the bathroom, and in the fog of sleep, it's real easy not to. They have to fight to get the seals back sometimes. So many times this just facilitates getting back to sleep. So if the high pressure cases are causing the patient to swallow air as well, whatever that can be done to reduce the pressure will be beneficial. Having the extra part too with a detachable PAP interface allows travel alternative to the PAP. Again, consistent with guidelines. Next. So we started by just attaching every kind of mask we could using two acrylic extensions on virtually any device. We would, in order to do that, we would use low fusing temperature polymer. In this case, the thermocryl that Airway management can provide. But we'd have to, the downside of it was it would have to cool with things in perfect position, you know, not too much pressure on the nose and sealing properly. So many times it could take 5 or 10 minutes of just standing there and keeping it from moving. Next. You could do any of the existing nasal pillow masks by attaching it right to the device. Next. One of the prototypes we have is for just a plug and play, essentially, a way of attaching a completely universal joint to the oral appliance itself, so that it can be done. The attachment is much easier, and you don't have to go through these trying to fit these devices with the thermocryl polymer. Next. And we were trying it out on all kinds of masks, and invariably the patients found them more satisfactory because of the stability of the seal and the ability to sleep on their side without disrupting the mask. Next. Even some of the older face masks, if you could find it, it just requires creating a hole and attaching a whatever type of prong or whatever design you can put together in your laboratory to attach it to the mask. But again, every one of these had to be just perfectly held in place to have it comfortable. Next. Which led to, again, attaching even a full face mask to the oral appliance. And I have a little video of this gentleman, I think next, that shows that when it's in place, and you can listen to what he says, just click one more time there. There you go. Listen closely.
Yeah, if he's pushing side to side.
He couldn't make it leak, and he did real well with it. This was our first attempt, so we refined a few things on it and have come up with some other attachments that will work as well. The next picture shows the brace that's on the forehead is not relevant. We just can remove that altogether. Again, less is more. And the full face masks that have the space to have this rod go through the center of it can be built in the same way. Right in the center, you'll see a black, it's like a grommet, and that's neoprene rubber so that it can allow for movement of the mask. There you go. This one, we took that forehead adjustment off and made it attached to a fork that is attached to the upper part of the appliance. And this gentleman, he was in the 22 centimeter range, and just the stabilization and edentulous, and just the stabilization of this reduced the pressure by at least a third. This is at the basis of our company's role in all of this and the substructure for all of this is a CAD designed 3D printed device that is adjustable like many of the pull forward devices. But the value as we see it is the extremely accurate fit to the undercuts of the teeth. It also has just a bit of a thermoplastic quality to it that makes it extremely comfortable and virtually no adjustments. I mean, I have to say it's unusual to have to adjust anything to seat this device. Next. So if we place a receptacle into the upper version of that, then it allows for these different options on the right to be had. In the case that the oral appliance were not sufficient to treat the patient and the patient was not acceptably compliant with the CPAP, many times this combination works beautifully. In the center, you'll see what are called bongos. It's an EPAP or expiratory positive airway pressure valves that can be held with this device. And we had, if any of you attending this would like to contact me, this is too short a presentation to really talk about, but it's an amazing result and comparable in the super severes to the application of the positive airway pressure from a pump and hose. Next. So this is our philosophy, and you begin to wonder if CPAP could be considered as a primary adjunctive therapy to the oral appliance. And thinking about it, stabilization of, regardless of severity, having the first step as a stabilization of the airway to see how you do, not inconsistent with the ABCs of CPR, simply see if the patient revives with a passive airway. If not, add pressure. And since we have without doubt shown that the effects of the combination can be better than either alone, it just needs to be more formally studied. But we've probably seen 500 cases where this approach was a good one. Next, please. And a treatment algorithm, I was just, there's no time to get in and talk about all this, but you know, the notion of how dentistry is going to manage this enormous public health problem is something we need to consider. And I think any time that we can maybe use mid-levels in our practice to satisfy the medical requirements of all of this, or have a different class of people you're going to treat well. Really impressed with the testing and see if the addition of PAP. I think there's just one more slide. Oh, sorry about that one. Maybe more, please. And just at the there, it's my my cell number, but you're welcome to visit .mad.us to see what we're doing, other products we have for this, and to feel free to contact me if you want to discuss more about the specifics of this therapy or the data we've generated. I'd be happy to do that.
All right, thank you, Richard. Appreciate that. And one thing I'm curious about combination therapy. I'm still actively involved in sleep labs, and it seems like the people that are now going to sleep labs are really sick individuals, and it's not unusual for me to get I had a patient that I scored a sleep study, and the pressures were 27/22. So, it just seems like the people that are really sick are finally getting some of the help, and I'm seeing some extraordinary cases. I just can't imagine.
We used to see some in that range. I don't think I've ever seen that, but certainly with an appliance now that can be designed and printed and delivered the next day, these kind of things should be explored, to stabilize the airway first, because that person at 27 centimeters water pressure will not be sleeping. Yeah,
that's a tough one. So, all right, great. I appreciate that info. And again, one of the things I didn't mention is everyone's going to receive a thank you email. And in that email, there's going to be contact information of all the panelists. So if there's something that Richard or myself or Marty talk about and you want to explore that further, I invite you to contact them. And if you need their contact information, it will be in the email. So for my part,
I'm sorry I took a little time there. I apologize.
The thing that's near and dear to me is testing. And so I wanted to talk about, I'm not going to talk about testing products, like the merits of one product or another. What I want to talk about is the considerations of, if you're going to test a patient, it's good to know, why am I testing a patient? And the answer to that question will help you decide on what kind of testing, if you're going to do any testing at all. So my goal is to help you make a decision in the testing area, not necessarily to promote a particular technology over another. So today, I'm going to talk about, what information do you need from testing? Are you going to just diagnose? I shouldn't say just diagnose, but is your goal to diagnose the patient? And certainly that's the case for almost everyone. And then in addition to the diagnosis, what other information do you need? Like, for example, half of all OSA is positional. There's some qualifying bits to that, but there you do need additional level, especially if you're treating with an oral appliance, and then technology is making a profound impact, and just in the past year or two. And so I'm going to talk a little bit about the technological advancements and how that can enhance your testing and how to keep it from hindering your testing. Okay. So how much OSA does your patient have? Okay, almost any reasonable device out there that can diagnose sleep apnea will tell you. We call this the AHI. The AHI's gotten a hit recently in recent history, and there's nothing wrong with the AHI, but I think people, the way they were using it and the way they relied on it, they put too much importance on it when there was other information that was as valuable, and it was being ignored because it wasn't quantified in a single number. So the AHI it is important. How positional is your patient? Okay, so how this and why position is actually leaving some of the new technology is because if you're going to end up on an auto-titrating CPAP, an auto PAP unit that senses how much pressure you need and delivers that pressure, do we care what position they're in if the unit's going to compensate for position changes? In that particular scenario, it's, knowing the positionality is much less important because the CPAP devices, or APAP more accurately, will compensate for the additional demand caused by positional apnea. Is that the case with oral appliances? It is not. So some of these really attractive, sexy, new technological diagnostic instruments don't give you body position. And as a dentist, depending on what you're doing with the data, you do need body position, so it's just kind of keep that in the back of your mind. Snoring. Do we care about snoring? Snoring is not a medical condition. It's perceived as a nuisance. Do we really care about snoring? Of course we do. The reason we do is because it's what our patients perceive. You can remedy an AHI, but if they're still snoring a little bit, nothing's been accomplished in certain scenarios. And you guys have faced this with your patients. Yeah, he still snores a little bit. Yeah, but his AHI maybe went from 70 to 18 or something like that, and he still snores a little bit. But from the patient's perspective, and usually the spouse, if there's still a little bit of snoring, it's like, oh, did we do anything? So yeah, snoring is important, obviously. How does the patient feel? Okay, we're not treating the AHI. I think a lot of us get focused in on, I've got to get this, to a certain point, and that deserves focus. But in addition to that, don't ever forget how your patient's doing. And as a dentist, you are at risk much more than a CPAP patient for this particular outcome, because if somebody doesn't perceive they're better, there is additional grief that a dentist has to face that maybe a physician who prescribes CPAP doesn't have to face. You need to know if the patient has central sleep apnea. Now, central sleep apnea is rare. What's more common is mixed or complex sleep apnea, and you need to know if that's present. Some of the technology available kind of lumps all this into an AHI, and you really don't know, and you have to vet out some of these complex apnea patients because they will not respond well to an oral appliance a lot of the time. And then I like to know, what's the quality of the sleep? How is the patient sleeping? Okay, questionnaires, we're all familiar with them. They're important, and it's a good way to get a sense of where your patient's coming from. And there's different kinds of questionnaires. There's questionnaires that insurance companies require, and there's questionnaires that give you invaluable information about your patient, and they're almost never the same. Okay, so you will need, if you're going to bill medical insurance, you're going to need specific questionnaires based on what your payers going to require, and Marty may bring that up, and I'm certain that he can attest to that. And then there might be, okay, what's the quality of your life? What's the impact the sleep apnea has had on your patient? Okay, that's not going to be in like the Epworth sleepiness scale. Okay, so get a questionnaire that that provides what is required to do what you're trying to do, and then also get a questionnaire that gives you a sense of how your patient's doing. Okay, so let's talk about the technological options. Okay, there are many. Okay, now if your patient is already diagnosed, and I know that Dr. Miracle gets the vast majority, if not all, her patients already diagnosed from a group of referring physicians. You know, that's an enviable position which she's earned and worked hard to get there, but it's not where you start. Okay, so some of us will need to kind of develop our own patients, and we'll need to be active in the diagnostic process. And in those cases, again, you know, as you learn and take courses, and this is not a course that I would say will completely prepare you to be a dental sleep medicine professional. It's designed to introduce you to the various topics. For my part, if you're going to be ordering a sleep study, then you should probably get a pretty good instrument. And maybe they're a little more difficult to use. There's more steps involved, but they give you the information that you need. If your patient's coming to you diagnosed from a sleep lab, you're going to get a sophisticated report that's going to tell you this information. If you're not, then the trap or the caution that I would say is like the Night Owl or the WatchPat 1. They'll give you good information, but they might not give you everything you need, all the information you need to do a good job with your patient. So in the case where you're ordering these tests and having physicians kind of read the study on your behalf, get a good instrument. There's the Knox T3 there. I'm a big fan of that one. There's the ResMed. ResMed did something interesting 2 weeks ago. They acquired the Night Owl, which is that little one there with the little green sensor in the person's fingers. What that strategy is, I don't know, but ResMed obviously is the #1 CPAP manufacturer. They make way more than half of all the CPAP units that are distributed, I believe, in the world. So they're a huge company. And so when they do something, they're the gorilla. And when the gorilla acquires a company, there's a strategy involved. And that strategy is, whatever that is, it's going to make a change. And if I had to guess, somebody said, hey, Jeff, what do you think that means? 100% guess. I expect that they're going to get into monitoring patients over time, because one of the nice features of the Night Owl is it measures, I think, 7 or 10 nights. So it measures several nights rather than just 1 or 2 nights, or even 3 nights in some cases. So who knows, but that is definitely going to have an impact on how we test. There's the WatchPat 1. They just went public and they did very well there. There's the patient safety. Okay, patient safety is very popular with dentists. And it's popular because it's really simple and it's basic information. In my mind, it's good for certain aspects of what we need to do, but not all aspects, and certainly not the diagnostic aspect. So, you know, there's kind of your options. There's the high end, the Knox T3s. There's the really easy Night Owls and WatchPat 1s, and then there's a bunch of products in between. And I would say the last thing I'll say on this slide is, if you're interested or you're contemplating making an investment in this area, if you want to give me a call and share with me what you're doing and where you're at and what your thoughts are, we'll come to a decision and I'll give you my thoughts on what would be a good instrument. Okay, so there's the couple pathways that I've alluded to, one of which is you need to, when you have a patient, maybe you do an initial consult, you do a questionnaire, maybe even send them home with an oximeter. Let's say everything points to the fact that the patient is likely to have sleep apnea. You refer them out to a sleep lab, okay? In those scenarios, you develop a working relationship with where you refer them to. That's a good thing. It's absolutely vital if you're going to do this long-term and grow your dental sleep medicine practice. You do need to refer out, okay? There's going to be cases where you get a case where maybe they have complex sleep apnea, or they're really severe, or for some other reason, they're just not going to be a good candidate for an oral appliance. You need to have a relationship with a sleep lab, Okay, so get used to working with the sleep lab as soon as you can. Hopefully soon, or maybe already, you're receiving diagnosed patients and the patient is mild to moderate and you have a healthy relationship with the referral source and they say, hey, in this case, an oral appliance is my first recommendation. Here's your patient. Those are awesome. I'm going to talk about reports in a second. In those scenarios, how you learn the information you need about your patient is that report that you're going to get from the sleep lab. Okay. And then lastly, I'll recommend, or I'll just mention service companies. You can, with a phone call, get a person diagnosed. So you do your intake, you do your questionnaire, you may or may not even do an oximetry study, and they need to be diagnosed. You call up your service company. And again, you're going to get a report back from a physician, just like you would on the sleep lab. And you need to get familiar with those reports that you're receiving. Okay, I can't do a talk and I can't help myself, but I'm really passionate about this particular topic. We are improving our patients' sleep. We are not in the business of reducing the AHI, okay? So this is 5 minutes of somebody sleeping well. So the reason that I show this is the top part of the screen has all those wiggly lines on there. Those are EEG, and that's somebody who's sleep. That's enviable sleep. That's 5 or 6 minutes of really good sleep, okay? This is not. Same amount of time, but it's a patient that has an AHI of 60, okay? So when you hear that AHI number, this is how that patient sleeps. So if the AHI is higher than 60, their sleep is worse than this. And the reason that I talk about this is there are 2 factors to a patient's sleep. One, we spend all our time looking at, and the other we almost ignore. And that is, one factor is the cardiorespiratory consequences of sleep apnea, the oxygen desaturations, the holding your breath, the CO2 buildup. All those things have a profound medical consequence. I'm not saying that's not the case. But in addition to that, and different from that, is what's happening on the top part of the screen, and the patient is sleep deprived. And sleep deprivation has maybe not as, somewhere close, but maybe not as severe, an equal role in the medical comorbidity. So ask your patient, how are they sleeping? Okay. If you got your AHI from 20 to 2 with your oral appliance, ask them how they're sleeping. Ask the spouse how they're sleeping, because a lot of times there's other issues. There's other reasons why they're not sleeping well. And we really want to help our patients with their sleep. Okay, wrapping up here, we need to know the patient's condition, okay, from a report. And I'm going to go through the report. These are some of the things that we need to know. I'm not going to go through this list. And I am going to send this presentation, at least my presentation, out to anybody that wants it. So if you're interested in the slides that I'm presenting, just let me know, shoot me an email, and I'll be happy to give it to you. But this is what you need to know, okay? Oops, there we go. Is the patient symptomatic? Oh, let me go back up. Okay, yeah, well, is the patient symptomatic, okay? The reason that I talk about this, people, one of the questions I get is, I did my intake, I did the questionnaire, they're very positive, they're tired, they're falling asleep in the chair. I did a sleep study and there's no sleep apnea. What do I do? Okay, if your patient's symptomatic, you need to get them to a sleep lab. That's one of the, that's like if you learned your patient had central sleep apnea. You know, if you said to me, what do I do with essential sleep apnea? I'd say, get them to a sleep lab. Same answer. If you do an intake, the patient's positive and the sleep study is normal. Get them to a sleep lab. We're looking for one sleep disorder. It's like 100 of them. Patient probably has one of the other 99. Okay. So, you know, just don't be afraid of that outcome. And actually, to be honest with you, it's a good way to show you're savvy to a sleep lab and say, hey, listen, this patient has symptoms. I didn't detect any sleep apnea. Please help them. You know, that just looks really good. Okay. Reports, just real quickly, become familiar with the report. So if you receive a diagnosed patient, do you just need to know they're diagnosed and have sleep apnea? Well, you absolutely have to know that. But in addition to that, wouldn't it be nice to know some of these other things that are in the report? So always get the report, and it's the report with the physician interpretation. Okay, but I'm going to be talking about the report because the physician interpretation is going to tell you what to do. Okay, the report's going to tell you about your patient. All right, so on the report, you're going to want to look at sleep efficiency. You know, is it above 80%? You know, so on and so forth. Get familiar with the sleep study. The reason you want to get familiar is what if the patient has an AHI of 50 and they slept for an hour and 28 minutes during the sleep study? Okay, do you have a good idea? Maybe, maybe not. Okay, and a lot of times sleep labs will miss that, or the sleep lab will say, I have the minimum requirement, which is 2 hours. So they have 128 minutes. They met that requirement. As a dentist, you know, just be aware of some of these report details. Go through, and there's these big charts in every good sleep report. Find out, you know, like there's CA, central apnea. Make sure those are all zeros. I am guilty of diagnosing a patient. A dentist sent me a patient. I have a group of physicians I was working with. They diagnosed the patient. I scored central sleep apneas. The physician noted central sleep apnea, and I sent that back to the dentist. Okay, so the dentist didn't catch it. Okay, it's not the dentist's fault. It was my fault. It was my error. And so the reason that error was caught is because the dentist called me and he says, Jeff, pull up this patient. I pulled it up and it says, why is the central sleep apnea the number one? Why is it not 0? And I said, I missed it. Okay, so this is why you want to get familiar with those reports. Okay, position. All good sleep reports have body position. Find it and make sure you understand. If somebody's AHI in this case is 7.2 on their back and 2.7 on their side, and their overall is 6. Okay, what are we going to do? We can get them to sleep off their back, and we're done. Or certainly the load is much less. But what's interesting about this is we have really mild positional sleep apnea and really severe leg jerks. Okay, so what might happen in this scenario if you don't catch those leg jerks? Well, geez, I got you off your back. Your wife says you're not snoring. Everything looks good, and yet you're still tired. That's because these leg movements. Remember that EEG I was showing you? That's still happening, but not from apnea, from leg jerks. Okay, so this is why you want to get familiar with these reports. All right, wearing an appliance. I'm a big fan of oximetry over time. Okay, because we do these snapshot diagnostic tests. They're great, but oftentimes we might miss a trend that only occurs over time. And if you have an oximeter, or more and more people, oximeters on watches, they're everywhere now, and measure how the patient's doing while they're wearing their oximeter. Okay, measure over time. All right, so the point of this page is, if you're going to send your patient home with an oral appliance and an oximeter, or like this is a circle. I like this circle because it does oximetry, but then at the bottom of this graph, it gives you a sleep histogram. And it's an estimate. It's an estimated histogram, but we measure it over time. We're not diagnosing anything. We're just measuring how our patient's sleeping. And we want these good numbers about the quality of their sleep. So we have oximetry and an estimate of how well they're sleeping over time. I think that's a great way to go, and a great application of technology. Okay, so at this point, I'm done. There's my contact information. And I am going to look for questions at this. What I'm going to do now is I'm going to turn the meeting over to Marty. And Marty, just give me a second, and I'm going to do that and do that. And while Marty's kind of getting set up, again, if there's any topic regarding testing or technology and you want to contact me, there's my email address. There's my cell phone number. I love to have that conversation. You'll be doing me a favor by calling me, and then if I can help you make a decision there, by all means. Okay, Marty, you're up.
Well, thanks, Jeff. And I hope you can hear me okay. And to people listening, whether you're listening live or to the recorded version, welcome. And I think there's a lot of great information that you're hearing in this webinar, and I hope to provide you some great food for thought in regards to medical billing. Now, I'm going to say this from the start, and I'm going to recap at the end that I invite you to email me. I'll give you my contact information, or call me. My cell is always available. I love to talk to people about this because one size does not fit all. Certainly, you may have specific concerns about your practice. There are local, regional, and state concerns to deal with many aspects of medical billing. I've talked to every office that we've dealt with, hundreds of them in the past 16 years, because one size does not fit all, and we're very flexible. But I want to help you. I'm very passionate about helping dental teams be successful in dental sleep medicine. And just so you know, I'm not just a dentist who does medical billing. I have a team. I think that nobody's been with me on my team for less than 10 years. And when I started this clinically in my practice about 16 years ago, there were many challenges, but I was always the systems guy. And I, with my team, was just gonna beat the problems that were associated with medical billing. And fast forward, after I sold that practice, the consulting and speaking I was doing to different practices and groups around the country became an active business. And now my full-time practice with my team is to help people so you can help your patients and be physician friendly as well, to be more successful at medical billing. Medical billing is nothing unless it's successful medical billing. So I always say that our system is no BS. We know what that stands for, but in our case, it stands for no buying stuff, instruments or equipment, and no buying software. That's no BS, because we don't sell anything. We sell our knowledge and expertise to help you. And I can be a straight shooter that way, because it's just as important what you don't need as what you do need. And unfortunately, there is a lot of bad info out there. And I try to help people make this simple and straightforward. Whether you like aspirin or non-aspirin, we are the pain reliever of medical billing in the dental sleep medicine world. And so we'd love to help you. So what is it really about? It's not about the BS. And I'm going to put the next slide up, because I think what that's all about, you could take it a couple of ways, but just look at it and see how you get this. But we really need to talk about sleeping with our patients. Now, I don't mean that the comical way. I mean that the serious way, but we can have fun with it, because that's where it starts. It starts with our conversations. We need to talk to our teams about sleep. We need to educate our teams as well as our patients. That is where successful medical billing starts, because patients are going to have questions. We don't want anyone on the team to be running where, let me hold on a second, let me find someone who can answer that to you. I have too many times where I have offices call me where the dentist is the only one who knows about sleep. So think about this, because your team is the first part of this that needs education, so that they can pass it on in your discussions and your screening with your patients. I have another presentation that I do, which is the 10 biggest mistakes in implementing dental sleep medicine. And we're not going to do that today, but I pulled this one slide out because reinventing the wheel, for some reason, I'm a dentist, so I think I'm allowed to say this, but I think our dental brains love to think that we can do it all and we're going to do it our way. Well, I hate to say it, but I know in working with as many offices for as many years as we do, that I think there's an over 80% give up rate, whether you want to call it failure rate or not, of offices entering dental sleep because they try to reinvent the wheel. They won't reach out for help. I know that Dr. Susanna is going to talk to you about how she helps in sharing her successful system with other teams. I don't think there's one right way to do this, but I know there are many wrong ways to do this. So let us help you. Whether you choose to have my team help you or somebody else, I'm going to show you with medical billing how easy it can be, not how difficult it should be. And that should not be the reason that you give up. Don't stick your team with this. Your team is already busy. They're very productive and knowledgeable at what they do in the dental world. If you try to, from step zero, stick them with things in the medical world that are not familiar with them, you will suffer. Your dental sleep medicine program will suffer. And if you're trying to build any medical physician relationships, they will suffer because your patients will go back and relay that you couldn't help them with their medical insurance, and right away that's cutting off the hand that might feed you. So please remember, don't reinvent the wheel. It doesn't need to be done. Just be careful and get good help, but get help. It's not the first time this has been done. No more incorrect coding should be done. Creative coding or cross-coding is a term from the 1980s. There's still people today using that code, whether they're trying to sell you cross-coding software or talking in terms of cross-coding. If that comes up as part of their method of teaching you, then find somebody else, because that is not what is appropriate today. You can leave money on the table, not for you, but money that would help your patients pay less out of pocket and make it easier for them to say yes if you don't have someone helping you who's really good at just getting benefits, verifying benefits, maximizing benefits, so you can ask your patient for less. It doesn't matter what we're buying as human beings. If we can pay less, we want to pay less, and we're more apt to say yes. Billing and auth denials. This is really important. Authorizations in the medical world are not the same as what we're used to in the dental world. When we talk about auths and pre-auths, we're talking about checking benefits usually. But in the medical world, authorizations are when sometimes medical insurance carriers require us to prove medical necessity. Not medical necessity in your eyes and mind or mine, but medical necessity according to the medical policies of the insurance companies, the medical insurance companies, which we're intimately familiar with on a national basis. So we know that. And here's what I hear from some dental offices: oh, we just don't want to get involved in this medical insurance. We don't, we're a fee for service. That's a famous dental term. Everybody's fee for service, otherwise you're doing work for free. But dental offices, we're fee for service. We don't deal with dental insurance. But if you try, I have many offices like that who realize that to build this medical part of their practice, they have to help their patients. And it's a great thing. It's a good thing with medical insurance to treat this life-threatening and life-shortening condition. So let's say that you don't, and you say, well, we're going to give our patient the paperwork that they need to submit to their medical insurance. Yeah, good luck. If you don't think you can do it or want to bother with it, good luck to the patient. And if the patient tries to submit something that you provided the services when an authorization was required ahead of time that you skipped doing, the patient's going to get a letter of denial saying that the provider didn't follow the rules. So who takes the heat for that? So don't just jump forward and blindly do all these cases. The authorizations as a part of medical insurance are a necessary part of checking, no matter who's going to bill this, whether it's a third party, you or the patient. Manual insurance forms. Every week I have somebody call me that called somebody else and they're telling them how to fill out manual insurance forms. Well, guess what? Paper insurance forms, I should say. No medical practice, no medical doctor bills on paper. And if you're talking to someone who's telling you your dental practice management software can't print or submit electronically a medical insurance form, so here's a program that can do a print one and mail it in, talk to somebody else, because you're just up to scrutiny and digging yourself a hole that you could probably never get out of by submitting a paper insurance claim that human eyes have to look at instead of a computer, for starters. And the people that review these claims are not familiar at looking at the codes that we use, because physicians don't bill these codes. So paper claims are a no-no, just don't do it. This process, no matter what type of appliance, no matter what you're doing, is really a similar steps. I call it from aid to paid, or an A to paid process. It all starts with screening and education. And that includes you, that includes your team, and that includes your patients. Talk to your patients about sleep health. Let them know why you're concerned about sleep health. Let them know that part of this is because you're staring at their airway throughout every procedure you do all day long, and why you're concerned and what you're have learned, and help to educate them and screen in that process. And this is a wonderful practice builder, because it's not just the patient in front of you, it's their extended family. Almost everybody has a snorer in the mix. And, not only is it good to educate them, but you may gain some new dental patients in that process as well. I always say I'd love to be number one. Jeff just talked to you about testing. We're not number one. I feel that number one is screening and educating. I feel number two is testing. We'll talk a little bit more about how that testing can easily be accomplished or gotten. And then we come in as number three, because here's where the verification and pre-authorization, again, not at all meaning what you're used to in the dental world. We do that for you. And we do it thoroughly and completely, because this is really the most important part of medical billing. The billing is easy and successful when we do the verifications and authorizations. And when they're skipped, then you start banging your head against the wall and patients get upset because things don't get paid for. So after we've done that and gotten it back to you, you can now present it to the patient, because you have all the information along with the clinical information. When you take records, your impression, your scan, whatever it is, you're going to send that to us so that we can bill appropriately as the medical world bills. Time is coded and time is money, and billing that appropriately helps your patient to pay less out of pocket. In dentistry, we don't do that, but we have to learn in the medical world of our dental practices, not because I'm telling you now, Dr. Lipsy wants to bill more stuff. We model this after what's appropriate in the medical world. Put on your medical hat, because this is not dental business as usual. This is not difficult, but it is different. And then for delivery and follow-up, we will help you bill the appliance, the follow-up appointments. Everything is billable, helping you and your patient to get maximum reimbursement from medical insurance, to minimize patient out of pocket, and also to help you get more yeses to treatment. There are many questionnaires you don't need in today's world. I used to hear this so much. You have to buy our software because we have all these letters and all these screeners and all these questionnaires. There is no one right questionnaire. I believe in simple questionnaires if you're using them for simple screening of your patients initially. I've modified, I have some of my own. And by the way, when someone's our client, you get all this stuff for free. We don't charge for it. It's just because, you know, we're passionate about helping you. So whether it's a stop bang, a stop, I have my own stop G questionnaire, Aries, the Aries sleep testing device, and I don't favor that one, but they have a great questionnaire for when someone's getting sleep tested that you could use all or part of even before sleep testing. And yes, as Jeff alluded to earlier on, there may be some insurance policies that require certain questionnaires depending on the level of the diagnosed sleep apnea. Certainly an Epworth scale, an Epworth questionnaire is more relevant in some cases, but questionnaires are a good tool to help get the conversation rolling. I just can't stress enough that it's all about the conversation. Have these conversations. And when they're positive, move to step two. Step two is testing, which doesn't always mean you need a sleep test. And as you're going to hear from Suzanne, I think that her patients all come previously sleep tested, the best of all worlds. If that isn't the case and you're just developing this, you may decide that you need to implement sleep testing in the process. I can talk to you about many ways to do that. There's many devices, many systems you can use, whether it's home sleep studies or you're referring to the lab, or don't forget, we can always use a copy of a prior sleep study. And I get asked all the time, well, what if it's 2 years, 4 years, 8 years old? Well, it's still like an old perio chart. Patient comes in, tells you as the dentist, oh, I haven't been to the dentist in 8 years. I brought my perio chart from 8 years ago. Do you think it's still correct? No, it isn't, but it still gives us a baseline. If the patient had 8, 10, 12 millimeter pockets 8 years ago, and they're bragging to you that they haven't been to the dentist since, do you think it's gone away? Well, it's the same here. If they had significant sleep apnea 8 years ago, that's a great baseline. And yes, sometimes we can get benefits with a not current sleep study, but we do need a diagnosis. So don't discount the idea of getting whatever documentation exists. And not always, people don't like to do sleep studies, don't always chase a patient or provide a patient, here, take this home tonight, we need another study. I'm always thinking of what the patient is most easily going to accept, as long as that's helping us move forward again to treat this life-threatening and life-shortening disease. So keep the path of least resistance in mind for your recommendations. Positive, move to step 3. This is where we come in. As medical billing for dentists, we're going to verify, do the pre-authorization. We're going to determine the level of benefits for you. We're going to get any pre-authorization from the insurer that's necessary. Most dentists are going to be out of network with all medical carriers. We're going to take care of that out of network processing for you. And we send a customized, personalized report to your dental team. It's literally a financial arrangement that is print and present ready on your customized form that you can show the patient. So the bottom line is you're going to send us the medical insurance card, a copy of the physician signed sleep study. We're going to send you this financial arrangement ready to print and present. It shows the amount not covered by medical insurance, the unmet medical deductible, and the total due from the patient. You don't have to use this. You can use anything you want, but this is the way that we're going to give you what you need, because the patient is going to ask the how much question. We know that that's part of your case presentation. So the benefits are verified and authorized. That is now the time to move on to case presentation. I strongly recommend that you cover all patient and physicians' concerns. How much will my insurance cover? Can you bill my insurance? Why should I have to pay this up front? Physicians don't like negative financial questions. And while I almost hate to say this, I think that too often the case is, if you're building or working on building or have started to build any medical referral relationships, that they are more concerned about the feedback that they get from patients on how much you help them, including helping them with their medical insurance. Because if you don't, that physician's office doesn't want the hassle to deal with where you didn't help the patient in the ways that they do. Present the patient with the sleep study findings from the sleep doctor. When you're presenting the case, show what was recommended for treatment and present financials for getting started. I'll put in this sentence today with appliance therapy. Answer the how much question. That is a critical part of your case presentation. When you use medical billing for dentists, we provide these answers for every patient. We maximize insurance benefits to skyrocket case acceptance, and we help you to learn how to present oral appliance therapy to patients with the best chance of getting a yes. As I said, simple is my middle name. Our forms don't have complicated medical codes on them. After the case presentation, as you move along with each appointment, you're just going to check off on a simple 3-column form that you can fax or email us what you've done. We will code that. We will submit it electronically, and we will follow up, and we will get you paid for these cases. We do the billing. The check goes to you. Our total billing cost is only 10% of what insurance pays, but we're on the hook. If we don't get you paid, we don't earn that percentage. So, we know what we're doing, and we want to help you get paid. We want to make the patient be able to say yes to treatment by minimizing their out-of-pocket costs. As I said, we're incentivized to get the maximum reimbursement on your behalf. So we do all the follow-up. The medical payments and EOBs come directly to your office. When available, we'll even set up electronic medical insurance payments to your bank account. We'd love to welcome you to our family. Here is my cell phone. For those listening elsewhere, I'm on the West Coast, so you can't wake me up in the morning. I learned that because we have so many East Coast patients that my phone is off, because I used to get 4 and 5 o'clock in the morning calls. So feel free to call me anytime that's convenient for you. That's my personal email. I would love to have a call with you. I would love to offer a complimentary webinar to you and your office manager, your billing people, your entire team. I am, hopefully, as you could tell today, very passionate about helping you, and I'd love to help you at whatever stage you're at. We're very familiar with this. We work with all areas of the country, private payers and Medicare. We have medical offices always working with the dentist, but we have medical offices as clients. I have a dental school, a hospital as a client. So we're familiar with working with physicians of all types, especially sleep docs, to help you because they think differently. And I'm trying to put everyone's interest in my mind to relate to you to make this as successful as possible. So thank you for your time today. please reach out, and I look forward to sharing more thoughts that are specific to what you're trying to do for your practice. Thanks again.
Thanks, Marty. Suzanne, I think, Suzanne, just so you know, you're muted. So.
All right, okay, I'm back on. So I just want to thank Jeff and Richard and Marty for sharing their knowledge and sharing it with all of you. And I just want to thank all of you for joining us tonight. If you go to Practical Sleep Education on our website, you can see what we offer. Jeff and I decided to put our brains together and create Practical Sleep Education. And what we do is we try to help you and your team consolidate all the information that you've learned about dental sleep medicine, and then we make it a reality in your office so you can be successful and bring it into your office. It's easy to learn everything, but it's easy to do dental sleep, and everybody's afraid of doing it, but we can help you and show you the right way to do it. And what I did is I started probably dental sleep about 10 years ago, and I started from ground zero, and I have made it a successful service that I offer in my dental practice. My team and I, we probably produce between 30 and 40 appliances each month. And those come from referrals from dentists that I have like beat down their doors in the streets to get this going. So you can do this. And I'd love for you and your team to come visit me at my beautiful St. Simon's Island, and my team and I can show you how to make this a reality. And I hope you enjoyed the webinar, and I hope you have a wonderful, safe weekend. And thank you for joining us. And we're going to see if there's any questions.
Yeah. All right, Suzanne, that's great. I appreciate that. I think if there's no other questions, then we'll go ahead. Let me see if there's any. Thank you.
I've got one question regarding sleep studies.
Yeah, we sure do. So I think, do you still have MDs available to read our HSTs using the NUCs? Yes. So let's see, that was from Mark. Yeah, Mark, give me a call if you want to get that fired back up. Thanks for asking that question. And yeah, they can prescribe the oral appliance as well. Okay, everybody, thanks again. We'll call it a day. Have a great weekend. Again, thank you for attending, and we'll talk soon. Thanks. Bye-bye.